So, Dr. Nicholas Westers is a clinical psychologist at Children's Health and an associate professor of psychiatry at UT Southwestern Medical Center. He's board certified in clinical child and adolescent psychology and serves as the current director of programs for the Society for Adolescent Health and Medicine and the
Yes.
annual meeting, and
Yeah.
as chair. Can I ask whoever joined to please mute yourself? Thank you. Annual meeting and as chair of the Media and Communications Committee of the International Society for the Study of Self-Injury. His clinical and research interests focus on adolescent non-suicidal self-injury, depression, and high-risk behavior. And he is the host and producer of the Psychology of Self-Injury podcast, a resource for parents, professionals, and people with lived experience in self-injury. And he will be talking more about that during today's presentation. There will be a number of handouts available, as well as a copy of this PowerPoint and information on a link to that podcast that will be presented today for you. If you have any questions, please put those in the chat and we will address those. So, Dr. Nicholas Westers, it's all yours.
Thank you.
So I'll let you share your screen.
Okay. Let's see. I need to request control.
There you go.
Let's see. I'm trying to see if.
Let me stop sharing here. Let me see if that's the deal.
Let's see. How am I? I'm sorry. I'm clicking on share content.
Mm-hmm.
And I guess I'm not seeing that.
When you click share content, there should be another box that comes up.
I don't see it.
Is there another one that says window?
No, it just says share content and then hide share options. Okay. Let's see. Can you see my screen?
Nope, I see you.
Okay.
Hey, Laura, I don't think he needs to request control. I think it's just share screen.
Okay. So do you see a box to the left of leave?
Leave. Yes, that's the button I'm clicking, the share content.
Yep.
And I click it, and so let's see if anything pops up. Yeah.
Nothing? I can certainly run your screens or your slides for you if you would like. Oops, we just lost Dr. Westers. He'll be back in just a moment. If when he gets on, he's not able to share, I'll just run his slides for him, and that's not a problem at all. So we'll wait for him. In the meantime, we're thankful to have you here today in our presentation on assessing non-suicidal self-injury, the SOARS model. Dr. Westers from UT Southwestern will be our presenter, and we're having just a little glitch in the technical issues, and so I'm sure he will be back here momentarily, and we will get him back in here. As I mentioned earlier, we do have some handouts that we'll be providing you. The actual SOARS model. Now, anybody who has registered for CPAN and is working with our team here has received a copy of that. But if you have not registered, we encourage you to do so, as well as if you don't have that copy of that, to let us know. Dr. Westers, you want to try again?
Yes, I'm sorry. This is the worst that could have happened. Okay, here we go. Now it's allowing me to.
Okay.
Yeah, sorry, everyone.
All good.
This way. Okay.
We're seeing your Yeah, there you go. Click that and you're good to go. All right,
Okay,
thank you, Dr. Wester.
sorry about that. That was odd. Maybe it was good that I got disconnected. um, well, thank you for joining today. I hope that this topic is helpful for you, for everyone doing clinical work with not only children and adolescents, but I think adults as well in primary care or wherever you are. And this is a publication and a presentation that has really developed out of um, years of doing didactics with our pediatric residents here at Children's and UT Southwestern Medical Center who rotate through our adolescent medicine clinic, our adolescent and young adult clinic. And I began doing a didactic with them back in October of 2013. So I've done it every month. I met with our pediatric residents this past Monday. And a lot of the presentation today came out of interacting with our residents and knowing and learning about their needs as far as needing to know what to ask and how to assess non-suicidal self-injury, because very few physicians feel prepared, and that's based in research. And hopefully after today you'll feel prepared, where when you have a patient come in and they disclose a history of non-suicidal self-injury, what do? Do you send them to the emergency room? Can they be just referred for therapy? Can they be managed there in clinic in your office? And my hope is for after today that you'll have a good idea when you should refer to the emergency room or inpatient or just simply for therapy and being able to manage it. This is not like the craft, if you're familiar with the craft, where if an individual endorses 2 or more items, or the cage, but for adolescents, that they endorse 2 or more items, they likely have a substance misuse disorder. This is more of a clinically informative model that will give you an idea of how at risk your patient is for needing higher levels of care, specifically if they're at risk for attempting suicide. So my goal initially with the residents was to recognize that they probably only have 5 minutes, or if they only had 5 minutes with a patient who engages in non-suicidal self-injury, and you're in a busy clinic, what questions should you ask? So that was the first thing I wanted to offer is like, well, what questions should you ask? 2, why should you ask those questions specifically? And 3, how should you ask those questions? Because how we ask questions and how we make statements matters. Messaging matters. Certainly, especially as we talk about COVID and the pandemic and vaccinations and how messaging comes out is really important. And so what questions to ask, how to ask the questions, and why to ask those questions. And then I realized, how are the residents and the physicians that I meet with going to be able to remember this? So I ended up coming up with this acronym called SOARS and the SOARS Model, and published it in the July 2016 edition or issue of Contemporary Pediatrics. So it's open access, it's still online, and this is a PDF version that I had sent to Laura Young, who will be sharing with you as well for the article. So hopefully after today, you'll be able to explain key characteristics of NSSI, which you'll hear me use interchangeably with self-injury and non-suicidal self-injury, that increase risk for suicide. And then knowing that I've given you the SOARS model, so 5 letters, SOARS, you may not have time to go through all the questions that we talk about today. So if you only had time for 3 questions, what are the 3 most important questions? And then being able to provide or come up with ideas for providing brief targeted medical advice if you had more time to spend with a patient. And we'll get into each of those. And like you just mentioned, I launched a podcast on January 1st, and episode 16 will be coming out at midnight tomorrow night, so early Friday morning, on therapy with youth who self-injure, where I interview a psychologist in New Zealand about what therapy looks like in her practice with adolescents who self-injure. So you can have an idea of what a psychologist might be doing in therapy with a patient that you refer for therapy. And then a lot of this presentation today is also in episode 2. So I encourage you to check it out. It's on all major podcast platforms, Spotify, Apple, and then the website is, you can listen to it online at simplecast.com. But But I think it's always helpful to go over like the definition of non-suicidal self-injury to make sure we're all on the same page. And by the way, I'll probably be flying through a lot of this information so that way we can protect the last 10 to 15 minutes for questions and discussion, because so I'm going to present a lot of information. I'll probably talk very quickly, a lot of research and some examples from my clinical work. But I want to make sure that we understand that we're talking about the same behavior. So non-suicidal self-injury is purposely inflicting injury upon oneself that results in immediate tissue damage, done without suicidal intent, and not socially sanctioned within one's culture, nor for display. So tattooing is okay. We don't, a lot of times people say, well, is giving oneself a tattoo considered non-suicidal self-injury? And because it's socially sanctioned, we don't consider that, even if someone gives themselves tattoos. And I like to differentiate non-suicidal self-injury from self-harm, which is an umbrella term, an umbrella category under which NSSI is one behavior, suicide is another, eating disorder behavior another, substance abuse another. All those are formed, and other risk-taking behaviors could be considered self-harm. I also differentiate it from atypical severe self-injury, which is specifically self-injuring on the breasts, genitals, or face. And that's not what we're talking about specifically today. And that's also formally considered typically self-mutilation, which is an outdated term. We no longer use the term self-mutilation in the field. And first of all, most injuries don't result in actual mutilation, and those that do can be better classified by atypical severe self-injury. And then finally, we're not talking about stereotypic self-injury, in which we would often see among individuals with intellectual disabilities or autism spectrum disorders, although those individuals could engage in both stereotypic self-injury and non-suicidal self-injury. We're specifically focusing on the non-suicidal self-injury, such as cutting, biting, burning oneself, severely scratching oneself, and hitting oneself, among other behaviors. Overall, my hope is after today that you would be very self-aware of your interpersonal style when interviewing your patients about self-injury. One of the greatest takeaways, if you can remember to use a low-key, dispassionate demeanor and a respectful curiosity when you're asking these questions, is going to really open it up for your patient to feel comfortable talking about them. And it seems like this would go without saying, but very few of us, if any, will intentionally judge our patients. It just happens by the subtleties of what we say, what we ask, and how we say and how we ask certain questions. So being aware and just using a low-key, dispassionate demeanor and a respectful curiosity can bring a lot of validation to an individual's experience. So if we were to jump into SOARS, I know many of you are probably using the HEADS exam, the HEADS assessment, when you're getting a good psychosocial history of your patient. And this is not to add another letter to that. There are already like 3 S's, but typically I recommend asking this question in tandem with your suicide screening question. If you're asking, I know many of you are probably using the PHQ-9 for that, but if you do verbally screen for suicide, I typically recommend screening for suicide first, and then right after that, non-suicidal self-injury. And you'll see why at our next slide. But for the prevalence rates of non-suicidal self-injury, lifetime among adolescents globally show that 22.9% of adolescents have self-injured at some point in their life. So basically 1 in 5 young people has self-injured at some point in their life, and that's about 6 to 9% for adults. And then it's between around 12-13% for college students or young adults. But prevalence rates change depending on how we ask the question. And so when I talk about screening for non-suicidal self-injury within SOARS, I recommend giving examples using like a checklist format. For instance, I used to start my screener with just this first question: have you ever hurt yourself on purpose without intending to end your life or attempt suicide? But we miss a lot of kids or a lot of individuals, because when people think about non-suicidal self-injury, what behavior do they typically most think about? Cutting. And cutting is not the only form of NSSI. You have so prevalence rates are lower unless we specifically ask. And I simply ask, like, cutting yourself, biting, burning yourself, hitting yourself, severely scratching yourself. And that way it can really assess the episodic memory of the patient, so they can think like, oh, I did do that, I do that. I don't cut myself, but I do like constantly bite myself when I'm angry at myself so I can punish myself. So I recommend asking it in this way, and this is based in research. And the 5 letters here are what they stand for, and we're going to go through each one. Suicidal ideation, onset frequency and methods, aftercare, reasons, and stage of change. First of all, it's okay to ask about and screen for non-suicidal self-injury, just like it's okay to ask about and screen for suicide. There are no iatrogenic effects. It's not going to put the idea in their head if they haven't thought about it already. If anything, you'll find, especially if you ask the questions in a certain way, patients are more than willing to share with you their experience, especially if they feel like they're not being judged, if they feel like you're listening and able to validate. But if you only had time for 3 questions, this is going to be one of your first ones, of course, because you want to differentiate it from suicide and screen for suicidality. And the reason we screen for suicide ideation, other than to simply differentiate it from suicide for non-suicidal self-injury, is really twofold. If we think about self-injury as a way to cope and regulate emotions, which is really the primary method that most people endorse using self-injury for, there's one function of the behavior, one reason of the behavior that's actually most closely linked to suicide, and that's if they self-injure to avoid acting on suicidal thoughts. Research shows that they are at greatest risk of attempting suicide. So when I'm working with patients and families, obviously I use my clinical judgment. You're going to use your clinical judgment on when you're going to tell the parent about their child's self-injury if the parent doesn't know. But this is where I draw a line and recommend breaking confidentiality, the child's confidentiality, and telling a parent about their child's self-injury if they self-injure to avoid suicide. Because if that's their go-to coping strategy for suicidal thoughts, and it just stops working for them between their visit with you today and their 2-week follow-up or 3-month, 6-month, or annual visit, and you know that they're thinking about suicide, well, first you're going to be telling the parents about their suicidal ideation anyway, because of limits to confidentiality, and that being one of the limits. But also, if it stops working for them and the parents know or find out that you knew that they had been self-injuring to avoid suicide and you didn't tell them, then there could be some liability concerns there. But otherwise, you're going to be using your clinical judgment. And then the other reason why it's important, you can see here, risk of NSSI, depression, and suicide attempts. Research has consistently shown, including here at Children's and UT Southwestern, before I even started working here in 2012, is that among adolescents with depression specifically, those with a baseline history of NSSI are actually at greatest risk for attempting suicide, even in the future, even more so than those with a baseline history already of a suicide attempt, which is kind of crazy to think about, because the best predictor of future behavior is past behavior, where obviously if someone has attempted suicide before, then they're going to be at risk for reattempting in the future. But among this sample, a history of NSSI is even a greater risk for attempting suicide. So I recommend starting with a statement and then asking. I'll say, I know self-injury isn't usually about suicide, but some people may think about suicide whenever they cut, burn, bite themselves, whatever behavior they endorsed on the screening item. And I specifically start with a statement because a lot of young people have been treated as if their non-suicidal self-injury is a suicide attempt. And then they're erroneously and inappropriately sent to the emergency department or admitted to inpatient psychiatric programs, which we already know we all have shortages of beds in these hospital settings. And some of these individuals may be taking up space when, of course, they reserve right for treatment in their own right, because they're important, but they may not need that level of care, but someone else might. And so we want to make sure we're keeping these beds open. And I have also heard stories of adolescents who have disclosed this to their school nurse, where they're at the school and they said that they may have cut like the day or two before, and then the police show up and the adolescent is being handcuffed and walked down the hallway in front of the peers who are looking at out the class window saying, why is so-and-so in handcuffs? So they brought to the ambulance and then brought to the emergency department for further evaluation, when had they just had a presentation like this, they would know that they didn't need to do that, because it's not a severe form of self-injury like self-injury to the face, breasts, or genitals, which would be more the atypical severe, that might require that level of medical care or psychiatric care. So I start with a statement and recommend you doing that too, because it shows that you know that the behaviors are different and you are going to make decisions differently based on and how they respond. And then you can start the question. Do you ever think about purposely ending your life when you self-injure, when you cut, when you burn yourself? And again, there are no iatrogenic effects. So the O is really 3 in 1. When I first started doing this, it was just the O and onset and frequency. And I've since added methods because of research. And I wanted to make sure that this is most up to date, where some research shows that the greater duration of self-injury in years, the greater likelihood of attempting suicide. And some research has shown that the greater number of lifetime episodes or the greater frequency of self-injury, the greater risk for attempting suicide. But research has consistently shown that the greater number of different methods an individual uses to self-injure, the greater likelihood of attempting suicide. And this is consistent with our research here at Children's Health and UT Southwestern, where one method is cutting, whether it's with glass or a razor blade or a box cutter blade. Those are all we consider one method, even though they're different utensils, different forms of cutting. Cutting is just one method. Carving is another method, and it's basically cutting, but it's cutting words or symbols into the skin, which is just qualitatively different than a general cut. And so we consider that a separate method. So cutting, carving, I mentioned many others already, like biting oneself, burning oneself, severely scratching oneself, embedding objects under the skin to intentionally cause harm and superficial tissue damage. But research shows that the greater number of methods, even though most people use more than one method, the greater likelihood of attempting suicide. And so I will simply ask right at the bottom of the screen here, you can see what have you used to, or what do you typically use when you cut, when you burn, whenever you, or bite or I guess biting, we know what that is, but whenever you burn yourself or cut yourself. And the most common at this point in my career that I see lately, the last few years, is those little plastic pencil sharpeners that have the small blades inside that students will either just crush by stomping on them because they're just plastic and they can take the blade and hide it, and it's easy to grab and hide and take with them wherever. And there's also, I think, just one screw. They can easily unscrew it and grab the blade and hide it that way. But if we go back to onset and frequency, research is mixed here. And I believe there's some reasons for that. So for onset, it really assesses duration in years. So you could have a patient come in today to clinic that's 17 years old that cut when they're 13 once, and then once when they're 15, and then once 6 months ago. Well, research that's going to show 4 or 5 years versus a separate 17-year-old that comes into clinic later today that has been self-injuring almost nearly every day for the last 6 months. There's going to be 0 to 1 years in research, so you can see how that might be confounding. But I will still get at duration by asking when was the first time you self-injured and when was the most recent time to get a good window. Now, there is some research that is showing consistently that early age onset of self-injury is linked to attempting suicide if it persists into later adolescence. And by early onset, I mean before age 12, so really 11 and under. If you have a patient that comes in that's self-injuring regularly and it goes into adolescence, or an adolescent that's 17 that's been self-injuring since they were 10, then that's a significant concern for suicide attempt. For frequency, it's a little bit of a misnomer. It's really assessing lifetime number of episodes. Some research, including ours at Children's and UT Southwestern, show that the greater number of episodes of self-injury, the greater likelihood of attempting suicide, and the greater likelihood of attempting suicide multiple times. Other research, however, particularly among young adults, has shown, and college students, has shown that more of a curvilinear relationship, such that risk for attempting increases as lifetime number of episodes increases, and peaks around 21 to 50 episodes, and then declines afterward, yet still remains high as a risk factor for attempting suicide. And if we ask ourselves, what might explain this curvilinear relationship? What's this 21 to 50 episodes about that might put someone at greatest risk for attempting suicide versus 10 episodes or 200 episodes? Well, if someone's self-injured 200 times, then obviously it's working for them as a coping strategy. Otherwise, they would have found something else. So we believe that right around 21 to 50 episodes, it's still new enough that the individual is still wrestling and struggling with emotion regulation and may feel overwhelmed, particularly if there's suicidal thoughts that accompany the behavior, that they're at greatest risk. But if they continue to do it 100 times, then it's doing something. It's doing what they're wanting it to do or needing it to do in that moment. So I typically, rather than ask anyone how often they do anything, especially young people, they just simply say, oh, I don't know how often I do that. I just skip it and just say, how many times a week do you cut? Or how many times a week do you burn yourself typically? Unless they say, well, it's not every week. It's like, okay, well, how many times a month do you self-injure or have you self-injured? And so the first time, let's say that was 6 months ago, and the most recent time was this past weekend. So you have your window of 6 months, and they say 2 to 3 times a month. Well, twice a month, 6 months is 12 episodes. 3 times a month for 6 months is 18 episodes. So they're right at the 12 to 18 episode mark. And so you may want to keep an eye on your patient and follow up with them in a couple weeks or before their annual visit if you don't see them for that long, to make sure that as they get closer to the 21 to 50 episodes that they're not at risk for attempting suicide. Some of you may be familiar with the interpersonal theory of suicide, the interpersonal psychological theory of suicide that explains this relationship theoretically. So Thomas Joyner is a suicidologist out of Florida State, and in 2005 he published a book based on his research, and the title of the book is Why People Die by Suicide. And if we think about adolescents specifically, and if you're familiar with the Youth Risk Behavior Survey that the CDC puts out every 2 years, which is an assessment of a national representation of high school students in the U.S., grades 9 through 12. The most recent data from 2019 show that 18.8% of U.S. high school students seriously considered attempting suicide the preceding 12 months, so the past year. Yet 8.9% report having attempted suicide within the past year, which is really a high number to begin with. You're almost 1 in 10 young people having attempted suicide within a 12-month framework is just too high. But what moves the 18.8% of ideators to become the 8.9% of an actor and of attempter? So this theory posits that 2 things have to be present. 1, the desire to die, and 2, the capability to act on that desire. So the desire to die is what you might see through the PHQ-9, showing up through depressive symptoms. And actually in this theory, there's 2 constructs. A thwarted belongingness and perceived burdensomeness increase the desire for suicide or for death. And thwarted belongingness is just the sense that I don't connect with anyone, I don't have friends. And I think you may be seeing this more with your patients during COVID. I mean, so many people have been in quarantine for so long, or in isolation, online learning, or working remotely from home. So there's probably a lot of thwarted belongingness among a lot of us at this point. And then there's a perceived burdensomeness, and that's the sense that I'm a burden. The world would be better off without me. My family would be better off without me. And some of you treat patients that are, in a way, legitimate burdens with, they have a chronic medical condition that requires lengthy hospital stays or like many visits to the clinic, and families, like, it's financially costly and they might lose their jobs. So there's a burden, but burden doesn't mean negative, like, necessarily. I mean, anyone that has a newborn, I have a newborn at home, if they wake up in the middle of the night, if they're crying or they're hungry, it's a burden, but it's our time to show up as parents and show love, and it's part of the joy of parenting. So so those thwarted belongingness and perceived burdensomeness increase the desire, the 18.8%, but they don't translate to necessarily the suicide attempts. And so what has to happen, according to this theory, is this exposure to what we call painful and provocative experiences, such as a past suicide attempt. If you've attempted suicide before, you've clearly acquired the capability to attempt suicide again. Non-suicidal self-injury would be one. Combat exposure for active military members or veterans would be a painful and provocative experience. Eating disorders, substance use disorders or behaviors would be one that could increase one's capability to act on suicidal thoughts, because 2 things happen. This is relevant to this presentation with non-suicidal self-injury, is this: 1, increased habituation to pain, and 2, a decreased fear of death over time. So someone might just start biting themselves as a form of NSSI, but then that's just not enough to regulate their emotions, and the tissue damage isn't as severe to help them. So they might start to cut, or they might start to burn. Or I've worked with someone who cut and then they would sear shut the wounds with a cigarette lighter as a form of burning. So it's like 2 in 1. And so someone who may not have considered suicide, because it's a scary thing early on, well, years of this in greater number of methods and greater number of episodes might not be as scary moving forward. So sometimes I'll ask, have you found that you've begun to self-injure or cut more deeply or more often than, say, a year ago or when you first started, to assess that. So this is kind of where you want to assess onset frequency and methods, but it's not the most important question, not the top 3 questions. The next one is the second. So suicidal ideation after care is the second if you only had time for 3 questions. This is probably a no-brainer for you as you're listening and watching. I mean, you're medical professionals and you're the ones that are going to be providing care and taking care of wounds to these individuals who self-injure. But how we provide care, how you provide wound care is going to be really important in allowing them to open up and feel safe talking to you. So for me, I'm not medically trained, and I'm not expecting a non-medically trained individual to be able to answer these questions 100% correctly, or assume a child or adolescent is going to be able to answer them. But when I ask, how do you typically take care of the wounds afterward, or have you ever hurt yourself so badly that you needed medical attention like stitches, even if you never got it, it gives me a good indicator of how severe it is in their eyes. Is this a really severe ingrained behavior with deep cuts or significant burns that need medical attention that they're not, and they're getting these keloid scarring all over their body? Or is it superficial? And most of the time, ideally, they simply say, oh, it's, they hardly drew blood. I just used some scissors and it just trickled a little bit. So I just washed it with soap and water. And then I might ask, did you use any ointment or Band-Aids? And then they say, no, it just didn't even bleed that much. But it's still helpful for me to know. And then let's say they do come in and you see wounds, just being that need medical care, being matter of fact about it, and just say, oh, I see some open wounds here. And not treating them differently because they did it to themselves as opposed to it being an accidental injury, but being able to be matter of fact, neutral. Oh, I see there's some fresh wounds here. What have you tried to take care of it? Oh, you haven't? Well, let me make sure I clean it out and provide the proper care so we avoid an infection. And then the next time that you see them in your next visit, let's say you know that they've been very stressed and they've used self-injury as a coping strategy to manage that stress. You can simply follow up with that. It's like, oh, it sounds like you've been stressed, and I know that's something that that oftentimes might lead you to self-injuring. And I want to just make sure we're seeing if there's any new wounds. When I do your physical exam, I'll just make sure we're providing proper care so there's no infection. We want to we can minimize scarring if that's something that's important to you. Just being matter of fact, non-judgmental, rather than, oh, you did it again. Like, oh, why would you do that to yourself? Even if you're being honest, genuine, and trying to be caring, those are just inherently judgmental questions. So if you only had time for 3 questions, it's going to be suicidality, suicide ideation, aftercare, and this next one, reasons. This is really, really important because if you had time to provide your brief targeted medical advice, this is where you would do it. You provide guidance and feedback and advice based on the function of the behavior, based on what it does. So earlier we talked about self-injuring to avoid acting on suicidal thoughts, which is not super common, but it's common in a lot of the young people that we see that are typically at higher levels of care, like in our inpatient programs. It's more common there, but exploring them alternative coping strategies, because here the goal is really addition more so than subtraction. So adding healthy coping strategies is more important than subtracting unhealthy ones. Of course, you're going to advise against self-injury for medical reasons, health reasons, right? On the other hand, just telling someone to stop self-injuring, I mean, like, they already know that other people are not going to be approving of it. It's a stigmatized behavior. And so they already know that it's not good for them. So just telling them to stop likely won't get them to stop, but it will get them to stop telling you about it, or they might see a different healthcare provider as a result. So you can see that it's really important asking about the function of the behavior, because it validates that it does something for the individual. And there's also research showing that most people self-injure for more than one reason, and it changes. And sometimes there's multiple reasons in one episode. However, the greater number of reasons, the greater number of functions that self-injury serves, the greater likelihood of attempting suicide. So most of the young people that I meet with have a few functions of the behavior, most likely to decrease tension and regulate emotions is the number one most commonly endorsed reason. And interestingly, I'm going to go to this slide. The most commonly believed reason that I hear from parents, teachers, and other medical professionals is that people self-injure as a cry for help or to get attention. And that's one of the most commonly believed reasons that people self-injure, yet one of the very least commonly endorsed reasons for self-injury. So there's this big disconnect in our in the professional world with those that treating those and responding to those who self-injure. But most do so to find emotional relief, to end emotional numbness, and let's say they do it to get attention. This is going to be great for any of you that work with young people, because if that's what the parent thinks, and if truly there are times where the individual might self-injure to get attention, let's reframe that and use different wording. Like, what are you trying to communicate? What needs are not being met in this case? Like, what is it that that your mom needs to know, or your significant other, your partner, is important for them to know that you're struggling to get them to understand unless you self-injure, and being able to explore that. And then some rarely will self-injure to avoid responsibility or an unwanted experience. I've worked with young people and maybe you have too, whose partners threaten self-injury or even suicide at times if they break up with them. That's obviously an indicator of an unhealthy relationship, and it's just not fair. But some individuals get stuck in stuck in a relationship because an individual self-injures to keep them, and then they blame the other person, which we know that we are only responsible for our own behaviors. And then self-punishment is very common as well. It doesn't necessarily fit neatly into either of these categories. But going back to this, why do we ask about functions of the behavior? Well, even before we ask about it, we make a statement, and I highly, highly encourage you to try this, experiment with this, and start with the statement, it sounds like this has been helpful for you. Well, I mean, maybe not if they've only self-injured once, this might not make sense, but if it's like a pattern of 3 or more episodes, they've obviously done it for some reason, and it sounds like it works for them in some way. So that's why I acknowledge, like, it sounds like this has been helpful for you. Don't confuse that with condoning the behavior. We're not condoning the self-injury. We're validating their experience of it and showing that we know what we're talking about, rather than just judging them for it and telling them to stop. We're going to listen, and you'd be very surprised to see how people just open up once you make that statement, followed by the question, in what ways does it help you? What does it do for you? It's just a very compassionate and empathic way to ask, again, using that low-key, dispassionate demeanor and respectful curiosity. And then it informs your treatment plan, and also how severe the behavior is if they self-injure for so many reasons. So in the paper, here are some common reasons that I see. I'll give a few examples. To feel something due to feeling numb or empty, that's a tricky one, because that's a function of self-injury that's often associated with suicide attempts. Obviously, if someone is dissociating and self-injury kind of brings them back as a form of grounding, that itself is a risk factor for suicide, very close to self-injuring to avoid suicide. So in dialectical behavior therapy, DBT, probably everyone is familiar with, or has at least heard of it. There are some strategies for distress tolerance, and one is what they call ice diving. So I recall when I was actually in graduate school, so we're talking quite a few years ago now, I was working with an 18-year-old young lady, and she self-injured for many reasons. And sometimes it was to feel something because she was feeling numb or empty. And so we talked about using ice diving, where we had her fill a bowl full of ice water, or cold water and ice, and then just splash herself, kind of jolt the senses, awaken the senses. So there's not just numbness, and then there's that discomfort. And so she would sometimes do that, and it was helpful at times. And then I also encouraged her, like, hey, have you considered biting into a hot pepper? And so the next week, actually, she came back to our therapy session and said, oh, I had the urge to self-injure, and I did what you said. I had bought one of those hot peppers at the store, and rather than, like, when I was feeling numb and I had the urge to self-injure, I bit into the hot pepper. I was like, oh, how'd it go? Like, how did it work? She responded, it worked, but I hated it and I'm never doing it again. And so that was like a one-hit wonder for her. And so we explored that, that was helpful for her in that moment, and actually brought some emotion in the moment when she was telling me, because we were able to kind of chuckle about it. And so you might find taking a cold shower or recommending biting into a hot pepper for your patient if they self-injure specifically to end feelings of dissociation or numbness. The top one there, to reduce emotional tension and stress. Again, this is if you had time for brief targeted medical advice. You figure out that they self-injure to regulate their emotions and to decrease stress. One of my favorites is journaling. I recommend journaling. I think that's a great strategy. Exercising, drawing, talking to a friend. Some people will use deep breathing, and interestingly, there's some older research that show that that's not as effective for dealing with urges, and even with mindfulness techniques. Sometimes individuals become so mindful of their distress that they end up becoming, turning to self-injury. But that's just rare caveats that we have when we're talking about mindfulness for self-injury. But journaling, exploring with them what they already like to do for fun. So if you've done your heads exam and they like to go shopping, or I guess window shopping for some people, then that could be a great strategy. It's like, oh, I remember you said you really enjoy taking your dog to the park. If you have the urge and you're emotionally like overwhelmed and you have the urge to self-injure, have you considered maybe just going for a walk with your dog, taking it to the park? Because they already like to do that for fun, so that can help regulate their mood. But let's say they do this, they self-injure to communicate with others or get attention. Because I just do this a lot. Again, let's reframe this. Like, what are they trying to communicate? And I'm reminded of a 17-year-old patient who would self-injure after getting into an argument with her mother. And she would go to her room and she would cut. And her mom would come in, and then suddenly, instead of arguing, would be very compassionate and soothing and say, baby, like, don't cut. And so she was being inadvertently reinforced by the behavior from a psychological standpoint. Some people would say manipulated, but if any of you have studied psychology to any extent, you know that operant conditioning, behavioral reinforcement, is a better explanation than just calling someone manipulative, which I encourage you, I discourage you from ever calling a behavior that an individual engages in as manipulative, unless it's obviously like they have a gun to someone's, to someone, or a knife, and they're physically coercing them. But mainly because if anyone were to call you manipulative, like, how would you feel, right? It's an inherently pejorative term. But anyway, so if we're talking about communicating with others and being reinforced, in this case, the 17-year-old, her mom would comfort her. And so this would happen time and again. And so we talked about exploring alternative ways to get that need met. I asked her, like, what are you trying to communicate to your mom, or what do you need from your mom in that moment? And so I was asking her to really become self-aware and consider her emotions, identify how she was feeling, articulate that with words, and identify what she needed at that moment and make that request, which is really hard for any of us to do if you've been distressed and your significant other wants to comfort you and you don't tell them what to do, but they might just start guessing and start doing unhelpful things rather than just simply communicating our needs to our significant other. So in this case, that's what basically I was asking her to do, is communicate her needs to her mom. And in this case, it was, maybe you just need your mom to sit with you on your bed in silence and not even touch you at all. Just be there. And then maybe the next time, maybe you don't want her to sit in silence. You need some encouragement and your words of affirmation person. And so having your mom just lavish you with praise and love and kindness. Or maybe you want her to give you a hug and not say a word, or give you a hug and encourage you. And so being able to identify it and recognize that it can change in any given moment, in any moment of distress. Sometimes it's helpful for us to go for a walk, but sometimes it's not helpful for us. So I recognize that for individuals who self-injure as well. Well, the same 17-year-old was also texting her friends saying that, I am thinking about cutting. And what other 16, 17-year-old, if you were get a text from an adult saying that, like, how do you respond? And so her friends are, as teenagers, high school students, not knowing what to do, they just say, don't. You have so much going for you. And then she would self-injure and then text him back and say, too late, I already did. Or worse, she would sometimes take pictures of her wounds, and that's all she would send to them. Like after they said, like what's wrong, or after they said not to. And that's just like, who's equipped to see that or handle that? So I asked her, like, what is it that you're needing in that moment? What are you trying to communicate? And she responded, she's like, I just need to know that my friends care. I was like, okay, we can work with that. A friend might not know what to do when you send them a message saying, I'm about to cut, or I'm struggling in that way. But if you tell them, like, hey, I'm having a bad day, I need some encouragement. Well, that's what they're there for. They know how to encourage. So her friends started texting her back saying, oh, you're hilarious. Like, you're the smartest. You're smart. You're funny. You're pretty. You're the best on the basketball team. And then her needs started to get met. And then she ended up stopping self-injury. And interestingly, there was an underclassman on her basketball team that had learned about her history of self-injury, who also was engaging in self-injury, and then started texting my patient when she was struggling. This is after my patient had stopped self-injuring. And my patient would come in and she's like, this girl keeps texting me and like cutting and then sending me pictures. And I don't want to be your friend anymore. And I had good enough rapport with her to say, so it sounds like you know what it was like for your friends in that moment. And she did. And actually one of the handouts that that are part of today's presentation is how to help a friend who self-injures, that was inspired by that patient and being able to respond to friends who self-injure. So, and I think it's also important here to mention that as you're exploring these alternative coping strategies for these individuals based on the function that the behavior serves, based on the reason for self-injury, let's acknowledge the fact that it takes practice, and it's self-injury is immediate reinforcement and relief, and it serves its purpose pretty much immediately. However, journaling, I mean, that's asking someone to formulate thoughts, it takes time to write down sentences and write down the right words, and, or type it out, or exercising, it takes the energy to get up, go to the gym for some people, or go outside, or deep breathing. It just takes time, and I acknowledge that. I don't pretend like this works immediately, as fast or as nearly as quickly as self-injury, but it takes practice. And then lastly, so if you only had time for 3 questions, you're going to ask about suicidal ideation, aftercare, and reasons. It's the functions of the behavior. The last S is stage of change, and I think all of you are familiar with the trans-theoretical model of change, where it was developed for smoking cessation, and a number of individuals, including myself, have adapted it for other behaviors such as self-injury. It's interesting to know that not everyone who self-injures sees it as a problem. They might not want to stop. And so you could already do all this stuff and then be ready to send them for therapy referral, but they might not see a problem and might not want you to tell their significant other or their parents, especially if it's not suicidal, and get really upset. And so I simply recommend asking them, like, kind of play dumb a little, like, is this something you ever consider stopping, or you'd like to stop? So it kind of respects their autonomy, and you'll be surprised what they might say. Ideally, they'll say yes, and then that just opens the door for you to be able to make a referral for therapy. And this is an image I just kind of pulled from the internet, and to illustrate the different stages of change, because I believe simply asking this question to someone who doesn't realize that change is possible can actually move them from pre-contemplation to contemplation. And it might not seem like you're doing much when you ask them or do this because you're not doing therapy per se, but asking that and being an open ear is really helpful. And since you've already validated that they've self-injured for a reason, and it makes sense, like, as their way to cope, you've listened to them non-judgmentally, this is where you could actually create a wedge of change and ask them, what's it costing you? It sounds like it's really helpful in the moment, but what's it costing you in the long term, or even sometimes immediately? It could, like, if it's a child or adolescent, it could be costing them the trust of their parents, and in the short term, and then the long term, it could cost them their ability to learn how to cope effectively with emotions in a healthier way. And so I'm thinking about a patient I had who was 17, chronic medical condition, and she was referred to me with her chronic medical condition because of the psychiatric needs above and beyond her medical condition, and she was self-injuring very often. And I asked her this question. She did not want to stop, and I was like, well, what's it costing you? She's like, well, I can't think of it. It doesn't hurt anyone except for me. I was like, well, what about your mom? She's like, well, my mom doesn't like it, but it's not hurting her. And so she comes from a large family, and she was closest with her 7-year-old sister. And it wasn't until her 7-year-old sister one day came up to her and had drawn with a red marker all over her arm, lines and red marks, and came up to her and said, hey, look, I'm like you now. And for her, that was the kicker. That was the trigger. She had to stop. She's like, I cannot let my little sister, who I'm closest to in my family, follow in my footsteps. So it was hard for her. Like, we really processed it. She mourned the loss of what was in a way like a symbolic friend or coping strategy for her. She wept, and she eventually got these beautiful sleeves of tattoos all over her forearms, over her scars and over her wounds, and one to cover them, and two she didn't want to mess up her new tattoos, so it prevented her from cutting in those ways. And so that was last I heard, she's doing great, including with her medical condition. So in summary, I recommend, like, if you're doing brief counseling, that it always validate that the NSSI seems helpful to them. Just say it seems helpful, which would make sense for them to do it. It opens up, their responsiveness to you. Obviously, you're going to sensitively express concern about the behavior and advise against it kindly for health reasons, and then explore alternative healthy coping strategies. Addition is better than subtraction. And then offer to make a referral for therapy. And these are different forms of therapy and what it might look like in a snapshot in practice that's in the paper that I'm not going to go over here unless you have questions about it. And same thing, this is the little pocket card that's in the article that I would give to our pediatric residents. Every month I have little yellow cards. Actually, I have one up here in my office that's on the right. It's the one on the right in the screen. So the 3 key questions: suicidality, aftercare, how do you take care of your injuries, and in what ways is this helping you, the reasons. So here's some of my favorite resources. I'm sending in another link or a PDF with some of my favorites with books and websites. And these are probably the top 4 websites. ISSS, the International Society for the Study of Self-Injury, is at the top. And then, so I'd be happy to, it's 12:53. I'd be happy to answer any questions or discuss anything that anyone would like.
Thanks, Dr. Wills. We do have some questions that came into the chat while you were presenting. So I'm going to go up into here real quick and see if I can find them. So does trying to drown themselves count as non-suicidal self-injury?
So even though if it sounds like it resulted in non-death, so drowning oneself, I mean, if you drown, you die, right? Unless, I guess, you're able to be resuscitated. So the intention, if it's to harm oneself superficially and their tissue damage, then that would be the case. So drowning is more of a suicide attempt as opposed to non-suicidal self-injury, because there's no tissue damage, and the result, which is the intent, is likely death. So probably not.
Do you think that there are any increased amounts of non-suicidal self-injury due to social media?
That's a tricky one, yeah, because I always think about social media and its ability to, or its tendency to be the scapegoat. So I'm not gonna, when it comes to social media and just technology in general, I think it's how it's used and who's using it that is more important than just making blanket statements. But I see the concern. So because rates tended to kind of coincide, kind of like with depression, coincide with increased use of technology. But the only reason that there might be an indicator for risk for engaging in self-injury is if people were to seek it out specifically for self-injury or be exposed to self-injury through social media. On the other hand, social media is a godsend to a lot of people because they can finally connect with people who aren't going to judge them, who are more like them, that have self-injured. So they can help them recover. They might applaud them in recovery. But of course, there are some that's just triggering, a lot of triggering content. So I wouldn't say necessarily increased use of social media is causal to increase in rates of non-suicidal self-injury. There's no research supporting that. But if anything, there's both risks and benefits. And actually, one of the podcast episodes, we talk all about that on, I think, episode 5, self-injury in the internet. Not quite social media, but.
2 more questions, and I know the time's running out, and I'm going to post the QR code here. One is, how about coloring? And I would suspect that means coloring on oneself. And then the next one is, how often do these kids have an underlying psychiatric condition such as depression or anxiety?
Well, I'll answer that last one real quick. Is the majority of the time that, for instance, when kids get to me, most of the time the parents already know about the self-injury, but rarely do I see an individual who self-injures that's outside the context of depression or anxiety or trauma. But it's possible. There are high-functioning individuals in our society that don't meet a diagnosis or diagnostic criteria for mental health diagnosis or mental health disorder that self-injure, and they don't necessarily see it as a problem. And so it's possible to self-injure without a mental health condition, but typically it occurs in the context of depression or anxiety. And then for coloring, as a coping strategy, that's great. If talking about coloring on one's skin, think about harm reduction. That would not cause any tissue damage. So that can be great. I think some individuals might draw on themselves as a way to cope and might use a red marker like to mimic the blood or the wound. On the other hand, there's the whole, what about rubber band snapping, right? Like that's results in tissue damage, superficial tissue damage, but it's less severe than, say, cutting with a razor blade. So it's, again, thinking about from a harm reduction model, it's less self-injurious, but it would still classify most likely as non-suicidal self-injury if the intention is to cause harm to oneself, not just because someone's bored, like they're just snapping a rubber band because they're bored, or I know some therapeutic strategies, there's this thought stopping technique where someone will wear a rubber band, and to stop themselves from thinking about an unwanted thought, they'll snap themselves, like to kind of jolt themselves to stop thinking about it. So it does cause some pain, but and to manage that thought. So it gets tricky when it comes to, is that classified as non-suicidal self-injury? But coloring on one's skin, I would say no. I see kids who do that all the time. In fact, in grad school, I saw a 15-year-old who actually used an eraser. This is another common form of self-injury, causing abrasions on the skin. He created this intricate design on the back of his hand, which we might think as like self-injury. However, when I asked him about it, it was the thing to do at school. He just discovered, oh, you can make designs on your skin. Like, that's kind of cool. He was I think he might have had an autism spectrum disorder as well. But I can think of students and classmates who did that when I was growing up, and it's not a form of NSSI unless like they're doing it to intentionally cause harm to their skin and pain.
Great. There was actually a clarification on the coloring. How about coloring as a way of coping instead of journaling?
Or both together. Yeah, I think that's great. There's those adult coloring books. Those are great. Now, these are all distraction techniques, which serve a purpose. They don't necessarily get at the core, but yeah, coloring is really good, and yeah, it's fun.
All right. And then I have a question as well. So my question is, as you talked about the rubber band snapping, does one maybe less injurious type of behaviors lead to something that is more, not necessarily lethal, but more painful maybe? Or more
Possibly.
severe?
Possibly, if it's non-suicidal self-injury specifically, kind of going back to the interpersonal theory of suicide, where the habituation to pain, they might need to do more to get the same effect, which is for suicide, clearly, because this increases one's capability. They acquire that capability to act on suicidal thoughts, which is why we want to make sure we treat each episode as important, or any self-injury as important. I'm thinking about a 10-year-old that I saw a few years ago who got in trouble at school because she and a male peer were cutting together, and they were kind of doing it as a joke and just kind of a challenge for one another, and the teachers found out and ended up in therapy, and the mom's like, oh my goodness, is this like are we doomed here? Is this like, am I too late? And it was only a few episodes, and so doing an assessment with this child showed that it wasn't to cause harm intentionally or to cause pain intentionally. It was more of a challenge and one of those fun things that she was bonding with, which is interesting because pure bonding can be a function of non-suicidal self-injury. She stopped self-injuring. However, what I did tell the parents, and when we know, again, early age onset, if she were to continue that behavior, she would be at increased risk for self-injuring worse and be at risk for suicide. On the other hand, like, she might struggle a few years from now emotionally and remember what that was like when she cut 3 years ago when she was 10 years old. So she's more at risk for re-engaging in non-suicidal self-injury than maybe a separate 10-year-old who had never done it. And yeah.
Okay, great. I really appreciate your time today, Dr. Westers. This has been an incredible presentation and one that is so important. We thank you for that. For folks that are still on the call, if you are interested in receiving the information from Dr. Westers, please complete the evaluation form. You can either do that through the link and type that in or through the QR code. You can also email us at cpaninfo, that is CPANINFO, at uthct.edu, and we will get those materials out to you. Dr. Westers, again, thank you very much. We appreciate your time, and y'all have a wonderful afternoon.
Thank you.
Thanks again.
Thank you for the invitation. And actually, I think I'll be presenting